Thank you, Mark. What a wonderful panel. I was reflecting on Liz's comment about the CMMI directors about being people who come to the work with a belief in innovation and a level of optimism about being able to improve things. And I think of the HCPLAN community as having those same characteristics. So good afternoon. My name is Dr. Alice Chen. I serve as the co-chair of the Executive Forum and also of the Evidence-Based Prevention Work Group. During this section, I'll be providing high-level overviews of each of our four work groups. Want to share both our work to date and what we're planning for the year ahead. So I'm going to start by picking up on a thread from the last panel around tech-enabled healthcare, which is chaired by Dr. Mark McClellan. And clearly, as you heard from the panel, this is a pivotal time for technology and AI. There are myriad of opportunities to address administrative burden, enhance access, streamline care, accelerate discovery. So the work group was established to advance CMS and CMMI health tech priorities by engaging industry subject matter experts, promoting cross-sector collaboration, and encouraging alignment around key priorities. This group provided pre-launch support for CMS's health tech ecosystem, whose goal is multi-stakeholder alignment around a shared framework for data and access, including the CMS interoperability framework. And the members provided key input on issues including stakeholder participation, technical considerations, and data privacy and trust. As they've gone through the work, they've identified areas where health technology may have the greatest impact. So examples like cardiometabolic health, patient navigation, and again, this always comes to the fore, data privacy and trust. Looking ahead to 2026, the work group is excited about continued partnership with CMS to advance its tech priorities focused on empowering people and improving care, which is a good segue into our second work group, patient empowerment, which is chaired by Dr. Judy Zerzenthal, who opened the meeting today, along with Karen Dale. And here, I think the context is a recognition that patients are people first. You know, even the sickest patients ideally spend a minuscule part of their lives as patients in the formal healthcare system. And we also know that behavior profoundly drives health outcomes. So impacting this positively can help drive measurable improvements in population health and reduce overall healthcare costs. Again, that fairly straightforward charge to CMMI, you know, improve outcomes and lower costs. So this work group was established to identify leading practices and effective approaches to scaling strategies to drive sustained behavior change and empower people to actively engage in health. They have spent the last few months developing a patient journey map to identify both patient empowerment opportunities and potential barriers, which we know can be significant. And drawing on real-world experiences and insights, the work group has prioritized three specific strategies: financial incentives, access to wellness activities, and personalized reminders and nudges. So the goal is to provide practical, actionable implementation guidance for a multiplicity of stakeholders, but within that, focusing on providers, plans, and purchasers. Looking ahead to 2026, the work group is excited to synthesize insights and recommendations into a patient empowerment implementation tool, which is again centered on the three priority strategies with the goal of empowering patients to manage their health and well-being. The third work group that I'll be talking about is newly launched Choice and Competition, chaired by Andy Slavitt. And the goal of this work group is to increase beneficiary choice among high-value plans, providers, and sites of care. So the team is bringing together national and regional payers, innovative risk-bearing providers, as well as independent providers to understand barriers to and opportunities for increasing beneficiary choice. So their work will help CMS and industry stakeholders define respective roles in creating a thriving open market, including supporting new market entrants and providers who are not already engaged in value-based care. Hopefully doing some of what I think Patrick was calling out, doing things faster and accelerating the movement towards value-based care by engaging people who really haven't been connected to date. So over a series of roundtable discussions, They plan to identify specific recommendations and actions that both public and private sector actors can take to increase choice for consumers. So a lot more to come on this one. And then certainly, last but not least, we have the evidence-based prevention work group, for which I serve as a co-chair along with my esteemed colleague, Dr. Asaf Bitten. And as the name would imply, the work group was established to support the adoption of evidence-based, effective preventive care interventions across the healthcare ecosystem. And specifically, it's focused on helping payers and other funders understand key considerations when thinking about evidence-based preventive interventions for testing and scaling in value-based care. We were really fortunate to be able to convene experts across a whole variety of fields, including prevention, implementation science, who come from academia, private companies, payers, purchasers, to inform this work. So if you can go to the next slide, I am excited to announce that the evidence-based prevention continuum was formally released today. And there should be a link that'll be shared. This is a product of quite a bit of work for HCPLAN and the work group members of the past several months, and is meant to establish a pathway to advance evidence-based generation and scale evidence-based prevention interventions into permanent care delivery and payment models. And it includes two frameworks that I'll be reviewing with you. So this is the first one. This is the levels of evidence framework. And on the left, you can see that the continuum defines 5 levels into which interventions can be sorted based on the strength of the evidence. And on the right, you can see descriptors of what we mean by each of these categories, from opinion informed, which are where reported claims are suggestive of a possible health benefit. And as you move up the continuum to the top, the scaled evidence-based interventions, where evidence is robust, rigorous, and can provide guidance on the effectiveness of different implementation strategies. So not only the clinical intervention is well accepted, but the implementation strategies have also been vetted. Organizations interested in scaling an intervention can use this tool to determine where it falls based on both the existing clinical and implementation data. So on the next slide, we have the second framework, pathway to scale, which aligns with the levels of evidence framework. So this is meant to describe how an intervention may evolve from being identified, tested, and eventually scaled as the evidence for it grows, along with observations about which payers and funders are likely to invest at each stage. So it's meant to help identify whether and when an intervention is ready to be implemented and which organizations may be most likely to do so. Just to call out, most payers and funders do require an intervention to have evidence demonstrating both the certainty and magnitude of net benefit on health outcomes and economic impacts before being widely scaled. But I'll walk you through from left to right. Interventions in the opinion-informed arena are generally not scaled and require further evidence generation before taking on the risk of scaling to broader populations. As you move to the right, interventions which fall into the emerging evidence or the evidence-informed categories generally require additional clinical and implementation evidence before they're scaled broadly. At the same time, some funders may implement these or adopt these in limited trials or piloting for targeted populations as a means to develop further evidence. So quick tests of efficacy. And then finally, as you move to the far right, interventions which fall into the evidence-based or scaled evidence-based categories are generally seen by payers, funders as being ready for broader scaling. The reason we're so invested in this continuum is that we hope it will help prioritize prevention and accelerate evidence-based investments in this area. We know that if we are intentional about where to invest in prevention, it will promote health and prevent chronic disease, reducing the overall burden on the healthcare system, saving limited healthcare dollars, and improving people's lives. So this audience, I hope you guys recognize how special you are, is the first group to see this evidence-based prevention continuum framework. We would really value your partnership. Please read the document. It's only 10 pages. Give us feedback, share it with your colleagues, particularly those that are thinking about or in positions to implement or invest in preventive interventions. So this wraps up our updates on the work groups. As you can hopefully hear, the four work groups have a lot of synergy. This is an exciting time in terms of the potential to engage people, patients, members, whoever you call them, whatever seat you're sitting in their care, support them with evidence-based preventive strategies, leverage technology, enhance choice to improve access, quality, and cost. So we are really excited to see how much progress the work groups have made and look forward to the collaboration that lies ahead.